All right, everyone, it's the top of the hour. We'll get started.
So thanks everyone for giving up some of your Sunday to hear this. I hope it's of interest. It's quite epidemiological, which is obviously fascinating to me and V, so hopefully you'll find it similarly. So I'm going to talk about some of my experience with Open Safely, just to say I don't have any conflicts of interest regarding this work. So before COVID, I was a member of the Electronic Health Records Research Group at the London School of Hygiene and Tropical Medicine. And that's a centre of public health research based in London, collaborating with lots of different groups around the world in different aspects of epidemiology. And our main focus in our group was about using big data resources to do different types of research. And my particular focus was on particularly in association to RAS blockade. So at the beginning of the pandemic, before I talk about that, because this is very global and I can see collaborators from around the world, I just wanted to tell you a little bit more about UK primary care data, because we are incredibly lucky to have this resource and it's not the same everywhere. So in the UK, we have access to pseudonymised electronic healthcare records from patients interacting with their primary care providers, their GPs. And one of the most common sources of this that you may have seen in multiple research papers is CPRD, the Clinical Practice Research Data Link. And this provides a wealth of pseudonymized information. So it's got the diagnoses of a particular patient, for example, if they've had previous cardiovascular disease or diabetes, in a particular coded form. It contains all of their prescriptions that can be developed into a continuous prescribing course for conducting drug studies. It contains information about whether they're referred to hospitals, and also the results of blood tests that the GP orders, including things like kidney function and full blood count. So a huge wealth of resources. And CPRD has historic and current information on about 10 million patients. However, when COVID-19 came along, we were really lucky to be able to think about whether we could develop even larger resources. And we were in our research group desperately thinking, what could we do to help the course of the pandemic very early on? And so we were very lucky to work with collaborators who were able to pull a lot of strings. So my boss at the London School, Liam Smith, spoke to Ben Goldacre, who's based at the EBM Data Lab in Oxford. And together they pulled together a plan to pull an even larger group of primary care records and link them to other data sources, specifically to conduct research into COVID-19. And that's what developed into the Open Safely platform, which I've been lucky enough to work on for the last 18 months. So this contains a number of different linked data sources. The original source of primary care data was from TPP, which is one of the two main UK providers of resources for GP data. And they, as you can see there, they cover about 24 million people. And that was linked to information about COVID tests, to information about hospital admission, including ITU and renal replacement therapy, for example, to death certificate data from the Office for National Statistics, and then other specific data sources, such as one of the intensive care audits in the UK called ICNARC. And this formed a huge source of data, over 10 terabytes, or to put it in easily identifiable forms, an Excel spreadsheet that's 6 rows wide and 60 billion rows long. Now, this data is accessible within a trusted research environment, and this is different to previous access to UK primary care data. And so I'm just going to explain a little bit about how we are lucky enough to have access to this information and the extremely strong security network that surrounds it. So at the heart of it is the data held by TPP, the GP care provider, in their extremely secure platform. And really nobody else outside TPP is able to access that data. So it's as secure as when a GP uses it for clinical care. But what they worked out, what they planned to do very early on in the pandemic, was a way to take sections of that data outside of the initial, the care providing network into a similarly secure server in aggregate form and link it to other sources of data, such as the COVID testing, which I mentioned earlier. And only the TPP team and then the kind of software engineers based in Oxford are able